Thank you for joining us today as we talk about the practicalities of antibody-drug conjugate therapy for solid tumors. Thank you for joining us here in person, and I want to welcome all of you joining online as well. Today's panelists includes myself. My name is Linda An. I'm a clinical trials nurse practitioner at Memorial Sloan Kettering Cancer Center. I work in the lung medicine department. I'm here with Dariana Espinal. She is a clinical trials nurse in the breast specialty at Memorial Sloan Kettering Cancer Center. And I'm also joined by Mikal Segal. She's a clinical trials nurse at Memorial Sloan Kettering, and she's part of the GI team. So just to get started, we're going to examine the rationale for recent evidence of antibody-drug conjugate therapy in solid tumors. So here's a diagram of an antibody-drug conjugate and what they are. So unlike conventional chemotherapy treatments, which can damage healthy cells, ADCs are targeted medicines that deliver chemotherapy agents to cancer cells. So there are the key functions. We have the target antigen here. It's a recognition of the target cancer cells. You have the antibody, which it's a guidance system for the cytotoxic drugs. You have the linker that bridges between the antibody and drugs and to control the release of the drugs inside the cancer cells. And then you have the cytotoxic drug here, the warhead for destroying the cancer cells. So ADCs, and how do they work? So we all know that conventional chemotherapies can damage both healthy cells and the cancer cells, but ADCs are targeted medicines that deliver chemotherapy agents just to the cancer cells. So they're selectively target antigen-expressing tumors. They bind to specific proteins on the surface of cancer cells, and then they're internalized into the cell, and once inside, the cytotoxic payload is released. Another pro to the ADCs is that there's membrane-permeable payload, so it can also attack the neighboring cancer cells, and this is known as a bystander effect. So if you see here, we have a HER2 targeting ADC, and it's targeting the HER2 positive cell, but there's also a neighboring HER2 negative cancer cell. So with the bystander effect, the payload will be able to enter the neighboring cell and kill that off as well. So this is all great science, and I'm speaking to a room full of nurses and nurse practitioners, but what do you tell your patients, right? Because patients are going to be like, I have no idea what you're telling me, and we're not going to sit here and show them these diagrams. So for me in my practice, I do talk about them as a missile, like a warhead. So there's three key components. It's the monoclonal antibody that targets a specific protein on the surface of the cancer cells. And then I have the chemotherapy drug, which is my cytotoxic payload. And then you have the linker molecule that securely attaches the cytotoxic payload to the antibody. And it breaks only when it's inside the cancer cells. So I basically tell my patient, it's a warhead carrying a bomb. It's going to enter your cancer cells and drop the bomb. And I like to just reach out to my colleagues here to see if they have examples of how they explain it to their patients.
So in the breast service, in the breast medicine service, we usually explain it to our patients in a way where they can understand. And we pretty much say we have HER2 expression in our body. You have overexpression of HER2 in your disease. So we pretty much have this therapy that targets to the HER2, and it goes directly where it needs to go and attaches to it and directly delivers the chemotherapy to the cell. And it's something that they like when we tell them this information, because it's something that's not just attacking the whole entire body, it's just going directly where it needs to go and doing the work where it needs to be done.
I like to use the Trojan horse analogy where the HER2 on the cells is targeted, and then sort of the Trojan horse sneaks in the cytotoxic payload, and then the chemotherapy does its job.
The next couple of slides, I'm just going to show you some of the molecules of the different examples of the ADCs. So this is an example of a HER2 targeting ADC, Trastuzumab Resistance, so it's TDM1, and here you can just see the monoclonal antibody, the linker is here, and the DM1, which is the cytotoxic payload. And here is the example of another HER2 targeting ADC, Trastuzumab Deruxtecan, TDXD. And here you can see the two differences between the TDM1 and TDXD. The TDXD is a little bit more powerful in that it does have that bystander effect. The payload is different. They use 2 different types of payloads. We also have a HER3 targeting ADC, Trastuzumab deruxtecan. This also has a bystander effect and has a high drug-to-antibody ratio, which is very important. There's another class of drugs called the TROP2 targeting ADC, Sacituzumab govitecan. This is a high-potency payload targeting drug, and it also has a high drug-to-antibody ratio. This is important because TROP2 is expressed in many solid tumors. So this, again, is another example of a TROP2 targeting ADC, Dato-DXd, and here are the 7 key attributes to that. So here's my summary again. So, monoclonal antibodies with unique targeting abilities have a powerful cancer-killing cytotoxic agent as payloads, and this provides the antibody-directed killing of cancer cells. Next, we're going to focus on ADCs in breast cancer, and my colleague here, Dariana, will be coming up to the stage.
Thank you. Hello, everyone. So for my portion, I'm going to be discussing and focusing on ADCs in breast cancer in particular. So targeting HER2 with ADCs, the development of the HER2 agents has been one of the most meaningful advances in the management of metastatic breast cancer patients. Targeting HER2 with ADCs continues to be studied with several ongoing clinical trials that can be potential for ADCs and can provide more promising treatment options for these patients in the future. So we're going to take a look at some of the case studies, and we're going to look at some of the clinical trials that are right now available for patients. So we're going to do a case study also before we go into the next portion of the clinical trial. So I want you to read this case with me, and I want you to keep it in mind while I'm doing my slides, and we'll come back to it again later on. So this is a 62-year-old Latina woman. She first presents to clinic with newly diagnosed metastatic breast cancer. So in presentation, she previously had a history of node-invasive breast cancer. She is ER positive, PR positive, HER2 positive. She underwent surgery, and then she was lost for follow-up. She developed abdominal fullness, right upper quadrant pain, significant fatigue, went to the ER where imaging revealed an 18-centimeter liver mass with multiple solid metastases. So she had a biopsy that showed metastatic breast cancer, ER positive, PR positive, HER2 positive, high grade. She had treatment with docetaxel, trastuzumab, and pertuzumab. After 4 cycles, she has 70% reduction in tumor burden. After 6 cycles, a complete response in the liver was shown. And after she developed neuropathy and edema, they dropped the docetaxel, but the trastuzumab and pertuzumab continue, and they actually added an aromatase inhibitor as well. 20 months later, she has progression in the liver with a new 1 centimeter metastases and as well as new lung metastases. So just keep in mind this case while we go through our slides. Okay, so now we're going to go into our clinical trials. So for the Destiny Breast 01 trial is a phase 2 study of trastuzumab deruxtecan in HER2 positive metastatic breast cancer patients. So for this trial, we looked at 184 patients, and they all had a median line of therapy of 6 lines in the past. They were all HER2 positive patients that received TDM1 in the past. The first part of this trial looked at 3 different doses, and when they found the recommended dose of 5.4 milligrams per kilograms, they moved on to the part 2 of this trial. The part 2 looked at the 5.4 milligram per kilogram recommended dose and looked at the safety and efficacy of this trial. So the efficacy of it was complete response rate of 6.5%. They saw a partial response rate of 54.9%. They saw stable disease rate of 35.9%, a median duration of response of 20.8 months, and an 18-month landmark overall survival of 74%. I actually treated a patient on this trial, and she was on it for 74 cycles of 3 weeks each. And the only reason why she ended up coming off trial was because although her CT scan showed that she was doing well on the drug, she was complaining of headaches. And we decided to do a brain MRI, and she developed brain metastases. So she came off trial. But she received radiation, and she did so well on it that she decided to go back on the drug as a standard of care treatment because it was FDA approved for HER2 positive patients. So it's pretty good. So So the safety of it, 99.5% of the 184 patients experienced an adverse event. 57.1% were of grade 3 and higher. Adverse events included decreased neutrophil count, anemia, nausea. 25 patients developed interstitial lung disease, and unfortunately, 4 patients did pass away from ILD related to treatment. But we took this information and we developed assessments that we were able to incorporate into the baseline assessments of patients coming on the next clinical trials to be able to capture this before it got to a grade 4 and a grade 5 level. And we're going to see what happens in the next clinical trials up front when we develop these baseline assessments for these patients. So the DESTINY-Breast02 and the DESTINY-Breast03 trials were actually developed, and these are phase 3 trials. The phase 3 trial, the DESTINY-Breast02, actually put patients in a ratio of 2 to 1. The 2 to 1 ratio was the arm of TDXT in one arm and the investigator's choice in the other arm. The investigator's choice in this case were capecitabine and trastuzumab versus capecitabine and loperamide. So the phase 3 trial for the Breast03, which we're going to be pretty much concentrating on, actually put the patients on a 1-to-1 ratio between TDXT and TDM1. So it looked at both of them head and head and compared both of them to treatments. So when you look at the trial itself, it put TDXT at a 5.4 recommended dose, and it compared it to TDM1 as well. And what they saw was that the TDXT patients did so much better as the best overall response than they did with TDM1, and it actually became a second-line therapy recommendation for patients with HER2-positive disease. So overall response rate, best overall response rate. So although we can see in this chart right here, TDM1 did do much better with the stable disease portion of it, but TDXT still managed to come up with the complete response and the partial response rates, and actually did much better with the overall response as well. So that's actually good numbers for them. So we looked at some drug-related AEs that was seen in more than 20% of the patients. We saw neutropenia, we saw anemia, we saw thrombocytopenia, nausea, vomiting, constipation, diarrhea. We did see some fatigue. It was actually pretty common. Some liver enzymes increased, decreased appetite, and the alopecia. The only thing with the alopecia in the breast medicine service that we saw with our patients was hair thinning. We didn't see complete hair loss, but we did see hair thinning and more in some patients than others. So when patients asked me they were going to lose all their hair, I pretty much just tell them it is a possibility. What we have seen in the past is hair thinning, but it can be more with some than others. So it just pretty much depended on the person. So the efficacy of this trial itself, statistically significant improvement in the progression-free survival compared with TDM1 in patients with HER2-positive metastatic breast cancer. It was consistent benefits seen across key subgroups and efficacy endpoints. The overall response of the TDXT was 79.7% versus the 34.2% in TDM1. The complete response of 16.1 versus 8.7%, and the 12-month overall survival rate of 94.1% of TDXT versus 85.9 with TDM1. So the safety of the similar rates of all grade and grade 3 or more drug-related adverse events between the arms. There were no grade 4 or grade 5 ILD pneumonitis events in either arm because we brought the baseline assessments where we incorporated patients being sent to pulmonology, patients being sent to do baseline PFTs, patients being educated and being reinforced and let them know, we need to know if you have shortness of breath, if you develop any upper respiratory symptoms, if you develop any fever, cough, chills, you need to let us know these symptoms because we are able to grab that before it becomes a grade 4 or grade 5. These data support TDXT becoming a standard of care for second-line HER2-positive metastatic breast cancer. So the NCCN recommendations for advanced HER2-positive disease, as a first line, patients receive pertuzumab, trastuzumab, docetaxel. If patients have recurrence within 6 months of neoadjuvant therapy or 12 months of pertuzumab, they were able to get this drug at that moment. But then the second line was the recommended and the preferred. Trastuzumab deruxtecan was a preferred second line treatment, followed by TDM1, and you can also do tucatinib, capecitabine, trastuzumab. We also put a third line and beyond lines here that were also recommended. So let's come back to our case. Remember our little lady, 62-year-old female, that came back with a new metastatic 1 centimeter in the lung, and she had also progression in the liver. All right, now that we know how HER2 positive in breast cancer is being treated in clinical trials, they saw such good results in the HER2 positive portion that they wanted to pretty much look at the HER2 low breast cancer patients. And the HER2 low is expressed with IHC of 1+ or 2+ with negative ISH, and this accounts for about half of all breast cancers and currently have no indication of HER2 targeted treatment. So is there an opportunity to change that, right? So we looked at some clinical trials. So the DESTINY-Breast04 was developed where trastuzumab deruxtecan versus standard of chemotherapy in HER2 low positive patients were studied. And the way that they saw this was a randomization phase 3 trial. So they randomized patients on a 2-to-1 ratio. Some people got the study medication, the TDXT, and the other ones got the physician's choice. The physician's choice included capecitabine, eribulin, gemcitabine, paclitaxel, and nab-paclitaxel. And what they saw was much positive improvement in overall results with the TDXT versus the physician's choice. Actually, yesterday, trastuzumab deruxtecan was granted breakthrough therapy designation for the treatment of patients with unresectable metastatic HER2 low breast cancer who have received a prior systemic therapy in the metastatic setting or developed disease recurrence during or within 6 months of completing adjuvant chemotherapy. So targeting HER3 and TROP2 with ADCs, we currently don't have any HER3 treatment that is FDA approved for HER3, but we have clinical trials that are currently working towards that goal. The overexpression of the TROP2 is more common in TNBC patients, and currently have an ADC drug called sacituzumab that is FDA approved right now for triple-negative breast cancer patients. So in a phase 1 trial of the U3-1402 HER3 positive for metastatic breast cancer cohort, these patients were medium line of 6 lines in therapy, and they looked at all subtypes, HER2 positive, HR positive, triple negative breast cancer patients, and the overall response was 43%. The median was 8.3 months of survival rate. So the ASCENT trial that we looked at is the sacituzumab ASCENT trial study design, where patients were randomized with the sacituzumab versus the chemotherapy physician's choice. And they also saw overall great response with the sacituzumab versus the chemotherapy. So for the ASCENT trial, we can see here the median free survival, progression-free survival was 5.6 months versus 1.7 months. The median OS was 12.1 months versus 6.7 months. And the results from this trial, the phase 3 trial of sacituzumab in HR positive metastatic patients, announced to be positive in the press release. So that was good too. So the DXD trial that we looked at for the TROP2 targeted ADC looked at 44 patients in total, and these were all triple-negative breast cancer patients, and they found an overall response of 34%. Okay, and now my colleague is going to focus on ADCs and GI cancers. Thank you.
Thank you, everyone, for joining us for lunch. And thank you, PeerView, and everyone at home joining us remotely on the webcast. Okay, so I'm going to start with a case to consider for gastric cancer, and we'll come back to this later. But this was my patient. She was a 68-year-old female, initially locally advanced HER2-positive gastric cancer. She did receive neoadjuvant and adjuvant FOLFOX. She was resected. She had a good treatment response, 90% treatment response, and and then received adjuvant FOLFOX. Unfortunately, as we see with about 60% of patients resected, she did recur in her lymph node, and she was treated as a metastatic patient, received first line with capecitabine, oxaliplatin, pembrolizumab, and trastuzumab. She had a good response to that. She was on that for over a year, and then she did have progression. We repeated a biopsy, which the initial biopsy was negative. They just didn't catch a spot with cancer cells in it. And we were trying to enroll her to a trial with trastuzumab deruxtecan where HER2 positivity needed central confirmation. So she was delayed a bit Fortunately, she was clinically stable and was able to wait. So we repeated the biopsy. It showed confirmed persistent HER2. It was 3 plus on IHC, which is highly positive. While waiting for the trial to work out, she did receive 1 additional dose of the first-line drugs. Targeting HER2 with antibody drug conjugates. So I just wanted to more broadly talk about HER2 for a moment. You could see it's a pan-tumor biomarker. We're primarily talking about lung, breast, and GI, but you could see it's in endometrial, cervical, breast, bladder, gallbladder. I also just wanted to point out, I think it's interesting, so the HER2 definitions are either IHC 3+, or if it's IHC 2+, then you get FISH, and that's considered positive. You can see there's a high percentage of breast patients that are, have what's called low HER2 positivity that are just IHC 2+ or IHC 1+. I wanted to just talk about also Trastuzumab Resistance, which is an interesting area of research. Specifically in esophageal gastric cancer, there's research that shows that about 20% of cases after being treated, patients after being treated with trastuzumab lost HER2 expression. So it's not standard of care, but some of the practitioners I work with do retest HER2, get like a repeat biopsy or a repeat endoscopy between treatment lines to better direct their care. Okay, so the Destiny Gastric 01 study, this study was for a heavily pretreated population in Japan and Korea. They had to have HER2 expression, obviously. The 2 prior regimens at least needed to include a fluoropyrimidine, which is 5-FU capecitabine, and a platinum agent, oxaliplatin or cisplatin. They also had to have a good performance status and high HER2. They were randomized to either get TDXD, trastuzumab deruxtecan single agent, or they received physician's choice of chemo, which was irinotecan or paclitaxel. They also included some exploratory cohorts for the HER2 low patients. Destiny Gastric 02, this was trastuzumab deruxtecan in advanced gastric GEJ cancers for second line. So this was after first line Traz and chemo. It was an open label phase 2 trial. It was directed at patients in the United States and Europe. They needed to have progressed on a trastuzumab containing regimen, good performance status, and the primary endpoints were overall response and progression-free survival, safety and tolerability. TDXD was given at 6.4 mg per kg every 3 weeks. Back to Destiny Gastric 01, in terms of efficacy, you could see a really nice response here with the overall response 12.5 months in the TDXD group versus 8.4 months in the chemo-only group. And you can see in this nice waterfall plot, all of these people responded, and the chemo group was much less. And the difference here in this chart, you could see that the very nicely shows the overall response rate much nicer than the chemo alone. So this brought us to approval for TDXD, trastuzumab deruxtecan, in January of 2021. It was approved as a second-line HER2 therapy for gastric GE junction. Efficacy for the Gastric 02 study, which was the second-line single-agent study, also showed a very nice response. You could see an overall response rate in 38% of patients. And this slide compares Destiny Gastric 01 and 02, and you could see how the plots here are very similar in that they all had, these patients were stable or progressed, and all of these patients had responses. And beyond this line here, all of these patients had at least a 30% reduction, and a few people had 100%, so complete responses. And similarly, in 01, you could see the plot is similar to the first one. Very nice response rate, 43% in the heavily pretreated population, which is important because typically, when we have patients that have gone through all their lines of treatment, they're like, what do you do? You offer a clinical trial. Maybe their performance status is not great already. So the fact that all these patients that have been heavily pretreated and this new novel drug was so successful opened up the floodgates to offer T-DXd in the second line, and now it's being tested in the first line. So this is a very nice positive study. AEs in the gastric and GE junction setting. On the left is Destiny Gastric 02, on the right is 01. You could see the AEs, sort of what you expect with chemo. Nausea, fatigue, some diarrhea, constipation, some bone marrow suppression. One thing that's not on here because the percentage was lower than all of these, but worth mentioning is pneumonitis and interstitial lung disease, which we're going to talk about later in greater detail, but I just wanted to point it out here. The percentage is the lowest here, so I believe pneumonitis is seen in about like 9 to 11% of patients that receive trastuzumab deruxtecan. So like what Diane was saying, you have to educate your patients on all these sort of expected things that you've probably talked to them about already, but also with the pneumonitis, you really want to stress that they tell you about any new lung changes, cough, wheezing, chest pain, chest tightness, anything, they should report it right away. Okay, these are some ongoing trials. There's a phase 3 Destiny Gastric 04, which is a phase 3, so it's trying to confirm the superiority of trastuzumab deruxtecan versus ramucirumab Taxol, which is a non-HER2 targeted regimen, but it is the standard of care second line. Destiny Gastric 03, also ongoing. It's a phase 1b/2 study. It's trying to use T-DXd in the first-line setting. So it's a study testing trastuzumab deruxtecan for first-line patients, and they're getting trastuzumab deruxtecan and durvalumab or pembrolizumab and immunotherapy, which are standard of care, and then they're being randomized to either get chemotherapy as well, which is either physician's choice 5-FU or capecitabine, or they're being randomized just to get the trastuzumab deruxtecan and pembrolizumab alone. I wanted to just briefly review the NCCN guidelines. This is a great tool for if anyone uses NCCN. This is the algorithm for providers, but the site actually also has a lot of good information for patients if you wanted to direct them to more education. But as you could see here, the second line, the standard for a long time was ramucirumab Taxol, which is not HER2-directed therapy. And then when we got FDA approval in January 2021, the guidelines were updated to include trastuzumab deruxtecan and for HER2 expression positive adenocarcinoma. So this was great. After trastuzumab in the past, there was no further HER2-directed therapy, and when we got this approval, now gave us a whole new opportunity to treat patients with HER2-directed therapy. Similarly, for esophageal and GE junction, these are for squamous, but for adenocarcinoma, the preferred regimen standard of care is Ram Taxol. And then now for HER2 patients that are persistently HER2, it's nice we can offer trastuzumab deruxtecan for HER2 overexpression in adenocarcinoma. So let's come back to our case study. Our patient that had surgery and then recurred, received first-line therapy. We tried to get her on a trial, and then eventually she was enrolled and she started second-line Destiny Gastric 02. She received trastuzumab deruxtecan every 3 weeks, and she initiated in January 2020, and she's actually still receiving treatment on study. So I wanted to bring up how does HER2 expression impact treatment decisions for our gastric patients, gastric and GE junction? So if HER2 expression is lost, they're typically not eligible for a clinical trial for HER2 disease. Repeat testing, repeat endoscopy biopsy is not standard of care. It is something that I see in my practice. But a new tissue sample for HER2 confirmation is usually required for clinical trials. So, like I mentioned already, the standard of care second-line therapy was ramucirumab Taxol. It's chemo. HER2 positive and HER2 negative. It wasn't biomarker-directed care. If patients have to decide between Taxol or Trastuzumab Resistance, you could discuss the schedule. You could discuss the toxicity profile. Trastuzumab Deruxtecan is every 3 weeks, which is nice. And the loading dose is 90 minutes, but subsequent infusions are 30 minutes. So this is a nice treatment option. Patients have, less treatment days, have to be on site less, and be able to live their lives as they please. The Taxol is 3 weeks on, 1 week off. It's they have to be on site more. They have more bone marrow suppression, and it's more, and the infusions are longer after the first loading dose. Relatively, Taxol becomes a longer infusion. So yeah, I find that oftentimes the provider will give their spiel, probably not spend too much time with the patient, or give them, patients often feel like intimidated to really talk to their doctor or to ask the serious questions. And then when the nurse goes in for education, they'll sort of dump all these questions on you, like, well, what do you think? And what should I do? How's the schedule? And, even if the provider said it, they were too nervous to listen. So I think our role is great in that they trust us, and we can explain it to them in a way that they understand. And if they're a good clinical candidate, the Trastuzumab Deruxtecan is a great option for the schedule and toxicity. Okay, to touch a little bit about colorectal cancer, Destiny CRC01. This was a trial with also heavily pretreated patients, greater than at least 2 lines. Prior HER2 treatment was allowed. Excluded patients, patients were RAS or BRAF wild type. Excluded patients had a history of long interstitial lung disease. The primary endpoints were overall response. And this study also had the primary cohort was for HER2 plus either IHC 3+ or IHC2 with FISH positive. And then they also had cohorts for cohorts B and C, which were HER2 low, either HER2 IHC2+ FISH negative or HER2 IHC 1+. So this showed a nice response in colorectal, and what's interesting about this graph here too is that the HER2 low patients also responded nicely. So typically HER2 low is, at least the gastric GEJ, is considered negative if you don't have FISH positive. So the fact that these would otherwise be considered negative and not have a HER2-directed therapy as an option shows that that needs to be, we need to rethink that. Okay, targeting HER3 and TROP2 with antibody-drug conjugates. So HER3, so these are all research areas. There are no approved drugs for HER3 and TROP2 yet. But you could see here that it's a good area for research. It's an area needed for research because HER3 expression is correlated with both a poor overall survival in both gastric and colon cancer. You could see low expressors of HER3, survival is here, and then if you're a high expressor of HER3, your prognosis is significantly worse. U3-1402 is being tested in colorectal, and it shows an effective. It's been shown to be effective for HER3 positive colorectal cancer, which is hopeful given the mortality. What about TROP2 as a target in GI cancers? This is also a big area of research. It's important as HER2 is expressed in about 47 to 66% of gastric cancers. Also, TROP2 overexpression is associated with a worse overall survival, so poor prognosis. There's a phase 1/2 basket trial that's testing sacituzumab govitecan now in GI tumors. So this is also a nice, a new area of research. Okay, I'd like to introduce back Linda Ahn, who will talk about ADCs and lung cancer.
Hi again. So we're going to focus on ADCs and lung cancer now. To consider, Mr. Smith is a 60-year-old man with EGFR mutant lung adenocarcinoma. He was previously treated with osimertinib. He developed disease progression and is currently receiving treatment with carbo-pem. His most recent CT scan shows overall worsening disease. So we did a repeat biopsy, which shows an EGFR exon 19 mutation, which is same as baseline. So targeting HER2 with ADCs. So HER2 is overexpressed, amplified, or mutated in a significant fraction of lung adenocarcinoma, but prognostic significance is not yet fully defined. But HER2 mutations are the most relevant targetable HER2 alterations in non-small cell lung cancer. Currently, there is no FDA-approved HER2-targeted drugs in non-small cell lung cancer. However, it is included in the NCCN guidelines. So if you were to give someone trastuzumab off trial, it is covered by the insurance companies. As of last week, April 19th, ADC trastuzumab deruxtecan was granted priority review in the US for previously treated HER2 mutant metastatic non-small cell lung cancer. In the DESTINY-Lung1 study, we looked at unresectable metastatic non-squamous non-small cell lung cancer. We looked at 2 different cohorts. Cohort 1 was looking for HER2 overexpression, and cohort 2 looked at HER2 mutant patients. So the most common AEs that we saw were pretty much similar to the AEs found in GI and the breast studies: nausea, fatigue, some alopecia. Drug-related AEs that were greater than grade 3 occurred in 46% of the patient. Most common was being neutropenia. And we also did see ILD that occurred in 26% of the patients and resulted in the death of 2 patients. This is the results of the HER2 overexpressed cohort as well. And the safety profile, again, very similar, both cohorts. So in summary, trastuzumab deruxtecan showed durable anti-cancer activity in patients with previously treated non-small cell lung cancer with HER2 mutation. It also showed preliminary evidence of anti-tumor activity in HER2 overexpressing non-small cell lung cancer. The safety profile was consistent with previously reported studies, and drug-related ILD, pneumonitis cases were of low grade, but it remains an important identified risk that requires early detection and management. DESTINY-Lung1 provides compelling evidence of positive benefit-risk balance with T-DXd in the second-line setting. There is a new phase 3 study in the works. It is looking at metastatic or unresectable non-squamous non-small cell lung cancer, and this is going to look at T-DXd in the first-line treatment of non-small cell lung cancer harboring HER2 exon 19 and 20 mutation. And this will go 1-to-1 randomization against pembro, platinum, and pemetrexed. So targeting HER3 with ADCs. So HER3 is expressed in 83% of non-small cell lung cancer tumors. The overexpression is associated with metastatic progression and decreased relapse-free survival in patients with non-small cell lung cancer. HER3 alterations are not known to be mechanisms of resistance in EGFR TKI in EGFR mutated non-small cell lung cancer. And targeting HER3 may be relevant across multiple EGFR TKI resistance mechanisms. So here's a broad range of resistance mechanism in EGFR mutant non-small cell lung cancer following failure of EGFR TKI therapy. So we know the efficacy of EGFR TKIs in EGFR mutant non-small cell lung cancer. That's been established. But however, the development of various resistant mechanisms commonly lead to disease progression. In practice, when a patient progresses on an EGFR TKI, we do a biopsy, a repeat biopsy, to see if they've developed any other mutations like MET. You can see in the chart here, patients can develop a MET amplification. So it is important to do a biopsy. But if the biopsy shows nothing new and you still have the EGFR mutation, the next line of therapy will be a platinum-based chemotherapy. This has an overall response rate of 25 to 44%, so not bad at all for platinum-based chemotherapy. The problem is, after your patient progresses on the platinum-based chemotherapy, salvage therapies after this have not been very effective. You see the progression-free survival is 2.8 to 3.2 months. So here we have patritumab deruxtecan. It's a HER3-DXd with a phase 1 study in advanced EGFR mutated non-small cell lung cancer. So there was a dose escalation portion, and then they expanded at 5.6 milligrams per kilogram. These patients were heavily pretreated with a median of 4 lines of prior systemic therapy. 100% of the patients did receive prior TKI. So the overall response rate was 39%, and here I think the most important thing to look at is that the median of the progression-free survival was 8.2 months. So this is compared to other salvage chemotherapies post-platinum, which was 2.8 to 3.2 months. HER3-DXd was also associated with manageable safety profile and low rate of discontinuation due to AEs. So you can just see the numbers there as well. So it's pretty well tolerated. And here you do see a small portion of the patients did have interstitial lung disease as well. And here, the most common thing that they saw was a platelet count decrease, neutrophil count decrease. And for the neutrophil count decrease, most of the patients did not require growth factors. They did bounce back on their own. What's not listed here is alopecia. I just bring that up because I know Dariana had mentioned in the breast patients, they just saw thinning. And that is what we educate patients, that you'll just have thinning. I walked into my patient's room and she was completely bald. She had lost all of her hair. So obviously it was very traumatizing. So there are that handful of patients who can lose all of their hair. What did help with her was the dose reduction. So, obviously we have these suggested doses, but maybe it was too toxic for her for whatever reason. So we did dose reduce her, and she did gain back some of her hair after the dose reduction. So in summary, HER3-DXd targets unmet needs in EGFR TKI-resistant EGFR mutant non-small cell lung cancer. It's clinically meaningful because the overall response rate is 39% with a PFS of 8.2 months. It's a low rate of discontinuation due to AEs. And this actually has opened up the pivotal HERTHENA Lung 1 study that's ongoing right now. So in the HERTHENA Lung 1 study, it's a phase 2 open label study, and we're looking at metastatic unresectable non-small cell lung cancer with EGFR exon 19 or L858R. They all had to have had prior osimertinib and 1 platinum-based chemotherapy, at least 1. They could have had more. There were 2 cohorts. There's a fixed dose given at 5.6 mg per kg, and then there was a dose up titration cohort. So targeting TROP2s with ADCs. So this is the Tropion pan-tumor study design. It looked at relapsed refractory advanced metastatic non-small cell lung disease. So the important thing to look here is that they looked at all comers. So they didn't just look at EGFR mutant patient. It didn't matter what your genomic alteration was. However, they did have a subset of actionable genomic alterations that included 34 patients. And this is also very promising. The overall response rate was 28%, and the median duration of response was 10.5 months. So the anti-tumor activity observed in heavily pretreated advanced non-small cell lung cancer with actionable genomic alteration is highly encouraging, with the overall response rate of 35% and a median duration of response was 9.5 months. So this is very important because patients who are heavily treated were running out of options, and this may be a good option in the future. So let's come back to our case. So Mr. Smith, who has been treated with OC and progressed on a platinum therapy, what would you give next? So now we're going to be addressing the practical implications of ADCs in solid tumor treatment. So why choose ADCs? Just to sum it up, they're conventional chemotherapies can damage healthy cells, but ADCs are targeted medicines that deliver chemotherapy agents to cancer cells. So it's more precise and safer than chemotherapies. So studies have shown impressive anti-cancer activity in different solid tumors, leading to first FDA approvals with many more likely to come. So for all of you in this room, how do we optimally integrate these ADCs into practice to maximize efficacy and safeties? So our next portion of this session, we're going to be more of a round table discussion about managing the AEs. So in talking about managing AEs, these were a couple of the ones that we thought that were very important. Nausea, fatigue, ILD, pneumonitis, diarrhea, ocular toxicity, and decrease in the LVEF. So we'll be going through some of the slides discussing this. So for nausea, we recommend providing antiemetics, ondansetron, your drug of choice post-treatment, small frequent meals with high-calorie bland diet, increased oral hydration. So for us in lung cancer, we do pre-medicate prior to treatment with Dex and the delayed whole Alopecia amend, and then we do provide delayed emesis regimen as needed. I'm not sure what you do in breast and
the pre-medications are similar.
Pretty much the same.
Okay. Fatigue, supportive measures. Patients will say they'll nap here and there. That's completely fine. If you do find that patients are, staying in bed all the time, that's not normal, and they may require dose reduction. I have a patient who actually ran every single marathon in the United States, and she just completed the Ironman in Texas.
Wow.
Yeah. And she's been on this drug for, I think, a year, Trastuzumab deruxtecan. So it's amazing. So, that's why these drugs are so amazing, because patients can live their lives and they can function.
Tolerable.
I don't have lung cancer and I won't be able to complete an Ironman. So when she sent me the picture this week, it was just so amazing. It was just so encouraging to see.
So going back into our polling question from a challenge question from breast cancer, there's actually 2 FDA-approved medications for HER2-positive patients. T-DM1 has been approved since 2013, and T-DXd has been approved since 2020. But when we look at the T-DXd, we want to make sure that we focus on the rare but fatal side effect of ILD pneumonitis. Early detection is key. It's rare, but it's fatal. We hold the drug with suspected ILD until further workup is done. We refer to pulmonology. We do PFTs. Now we do baseline PFTs, bronchoscopy. We initiate steroids as needed, and we do follow-up imaging as well. So the step 1 is to monitor. We always, check and monitor and follow up for suspected ILD. We want to make sure that the patient understands that it might not be something that they're even experiencing, but we can see it on the CT scan as well. So if they do follow-up CT scans, we'll be able to see it. And if something comes up, we will be able to hold the drug and monitor and do further workup. For step 2, we're going to confirm. So we're going to send them to get a CT scan. We'll do pulmonology consultation. We'll go do the PFTs to compare it to their baseline PFTs that they did at the beginning of the trial, and then we'll do blood gas as needed, and we'll do a sample of collection for labs that we will need to pretty much compare and see the patient status at the time. And the step 3 would be to manage. If it's grade 1, we will interrupt fully until it fully resolves. If it resolves within 28 days, we can maintain the dose. If it doesn't resolve before 28 days, then we can do a dose reduction. That's one of the things that we can, let the patient know so they don't freak out and say, oh, I really love this drug, because I have had that. And I always make sure that I mention to my patients, if you do develop these symptoms, don't be scared to tell me because you want to stay on the drug. I know the drug works, and I know it's going well for you and it's well tolerable and you can live your life. But if you are experiencing these symptoms, you need to let us know. It doesn't mean you're going to come off of it right away. We can do a dose reduction before we even get to that point, if needed. So that's important to tell our patients. For grade 2 and 4, permanently discontinue treatment, refer to toxicity management guidelines for Trastuzumab Resistance.
So one of the challenging things for me working with lung cancer patients is baseline, everyone has a cough and shortness of breath. So sometimes when they are asymptomatic, they're usually found on, incidental finding on a CAT scan. But the threshold, the take-home message is the threshold for ordering a CAT scan, if your patient has even the minimal changes in their respiratory status, I would order a CAT scan to take a look, because it can become fatal if you don't treat it. So early detection is key. So that is one of the challenges that we do see. Just really assessing the patients, really asking the questions. Is your cough any different? And walking them around, right, with the pulse ox on. They're always like, I feel fine, and then they're like, oh, I'm at 99%. And then you start walking them, you're like, oh my God, you're like dropping to 80. You're not fine. So I think it's very important to really assess these patients well, and then just key is to early intervention. So, this is what you were talking about. So.
Yep. Okay, so the patient education monitoring for signs and symptoms, coughing, shortness of breath, fever, worsening respiratory symptoms. Just advise patients of the risk and to immediately report these symptoms. It's important to educate patients on common side effects and management for each. Now, we also have the other side of the spectrum with patients where you're listing these to them when you're consenting them, and they already feel short of breath and they're already coughing. So they like, I think I'm going to get that because I always get all the side effects. And you have to make sure that you tell them it's okay if you are not sure what you're feeling to call us. Just make sure you call us, and that's my job. I will assess you. I will make sure that you are going to be receiving the further workup that you need. Too much information is not bad. So just make sure that you keep on stressing that to your patients.
I'm going to talk a little bit about diarrhea, also constipation. I'm sure everyone in this room is well versed in managing this, but diarrhea was mostly expected, but I think in my experience and in our experience, patients had a good amount of constipation as well. So start loperamide as needed as soon as possible. Our recommendations are 2 tabs with the first episode of diarrhea, an additional tab with each subsequent episode of diarrhea, up to 8 a day. But educate your patient that if they're really using that much loperamide, they should call you. You want to rule out any infectious sources, promote a bland diet, the Brady diet. You want to have them increase oral hydration, or if they are not doing well at home, to come in for IV hydration. Constipation, also over-the-counter stuff, you want to promote stool softeners, laxatives, hydration, adding fiber to their diet, getting some exercise, walking around to promote bowel movements. With the ADCs, we do see some ocular toxicities, mostly dry eyes, some inflammation, keratitis, photosensitivity. So for baseline prior to starting ADC, you really want to get, at least the clinical trials require an ophthalmology exam. And then if patients do start having any symptoms, you want to refer them back to the ophthalmologist to either do over-the-counter, wetting tears, or prescription eye drops. Decreased ejection fraction, similar to trastuzumab, the ejection fraction can be lowered with trastuzumab deruxtecan. So you want to get a baseline echo for sure, the way you would with regular trastuzumab. You want to monitor the patients for signs of heart failure, which could be difficult sometimes if, many patients have comorbidities and already take medications for various things. So you keep a close eye on this. You also want to avoid medications that prolong QTC, and get cardiology on board. Or if they have a cardiologist already locally, you want to tell them to follow up with them if you see any decrease in ejection fraction.
So the nursing implications for the new ADC era, Nurses should assess for and manage adverse events. We should provide patient education, including about signs and symptoms to look for and how to report them. Patients should have adequate supportive measures to prevent and reduce adverse events. So our next portion will be Q&As from you guys. I do have some in front of me. It says, do you see ILD pneumonitis occur more frequently in the first 3 months of treatment, or can it occur at any time during treatment?
That's a great question, actually. We actually have seen patients that do ask these questions when we are consenting them. It's just something that, as the more cycles that I'm getting, I have the more potential to receive this pneumonitis. And the answers, we have not seen that. We haven't seen patients. It's not a cumulative thing that they were going to get pneumonitis afterwards. It's just something that happens, and it's something that we have to continuously look at. But it's not something that accumulates. No. So that's a great question.
How do you all feel about treatment breaks? So this is a good question.
Treatment breaks?
Treatment breaks, yeah. Giving breaks in treatment. I like this question because this is going to bring up, what we don't want to talk about, which is COVID. We've had a couple of patients who got COVID while on these ADC drugs, and we did have to give them long treatment breaks. In one of the clinical trials, they were very strict. We know that you can still test positive even after a certain amount of time. The requirement was a negative PCR, regardless of how it being asymptomatic, and the CAT scan had to be clean. So I think the longest treatment break that I had a patient get because of COVID was about 6 weeks. And he still ended up responding, restarting treatment. So treatment breaks, I think, I feel okay with it, but I think, you give it too much time and you're giving the cancer a chance to grow, so.
In my experience, I think if something's working, why rock the boat? I like to keep going. If it's working, you're doing well, you have quality of life, especially with ADCs. It's such a good, tolerable drug. You still continue to have all of your daily lives that you do, and you're able to run marathons, and why rock it, right? It's working, keep going, and don't even mess with it.
I think from a palliative perspective, if you have a metastatic patient and they've been stable for a while, or maybe they have no treatment options and a phase 1 is not really something they want to participate, or there's not something that you think would be successful for them. I've had providers give treatment breaks, and we'll follow them with CAT scans, and they'll stay stable. And I think, if a patient asks me my opinion, I would promote that, especially in the metastatic setting. To have time to live your life and spend time with family, I think that's important.
Another question here is, how often do you repeat echo?
Oh, I want to say like 3 months?
3 months?
Yeah.
About every 3 months we repeat echo.
You wouldn't expect ejection fraction to be affected that quickly or in a shorter interval. And also, if they're symptomatic, you should do an echo.
Of course.
Recommendations for managing ocular toxicity, I think we already went over that.
Yeah.
I think the most common ones that we do see with patients is the dry eyes. And in the beginning, I actually didn't even think about it. Patients were like, oh, my eyes are dry. And I'm like, oh, it's your allergies.
Yeah.
But you start noticing a trend that these patients receiving ADCs, they do have more frequent dry eyes. So just, over-the-counter, refresh tears, artificial tears. And if it's bad enough, we do send them to ophthalmology again. Someone just asked a clinical trial question. Can you explain what is meant by a basket trial?
So I think a basket trial is, it sort of starts with one direction with the option to move into different disease groups or to add different drugs. So, for example, in GI, now we have a trial for a Nectin-4 target, but it was in breast, and now it's moved. They found there's new data that shows it's positive in GI cancers as well. So now, even though it was opened in the breast service, now they transitioned it to GI, and now we've taken over, and now we're enrolling GI patients.
Another question here is, what is the best sequence of treatment? I guess that would really depend on the disease group.
Yeah.
Like I said, for EGFR mutant lung cancer, after Tagrisso and platinum therapy, If available, patritumab deruxtecan, it's not FDA approved, so you can only get the drug via clinical trial. That's what we would recommend. And for breast.
Yeah, same thing.
So something interesting that's a good question. The Destiny Gastric 03, the two groups are randomized to either get TDXD and Pembro alone or to get TDXD, Pembro, and chemo. And so chemo is the mainstay for first-line treatment. So it's a tough call, but if you have an elderly patient or somebody that's frail or maybe has already had neoadjuvant treatment with cytotoxic chemo, receiving TDXD and Pembro alone would be a good option for them first line, especially given the benefit seen in second and beyond lines. Giving it up front in a clinical trial setting might be a good option for that type of patient.
For side effect management, like telephone triage and like red flags. So yeah, we get a lot of telephone triaging. So what are some of the things that we look for? Again, any changes in respiratory status, that would be a big red flag. Yes, and even if it's a minor change, I just want to overlap with another question because someone did say, do you order a CAT scan even if there are small oxygen changes? I think that would depend on if they were having any other symptoms. Like if someone dropped from 99 to 97, I don't think that would cause me to have a red flag. But if it was associated with, yeah, I am coughing a little bit more, or yeah, I do feel myself, being a little bit more short of breath when I walk down the block, that would, be enough for me to order a CAT scan. I don't know, other red flags that you get for calls?
I think it's important to stress to our patients too that, person receiving the triage may not be us, and we are just going to get the message. So make sure they let them know, I want to speak to my clinical trial nurse as soon as possible, just so we can speak with them. But if it's like on the after hours or on the weekends and they feel like it's something that they have seen a change, they should definitely go to their neurosurgeon care or ED just to get evaluated, but not to forget to call us, because sometimes they do go to the hospital and get admitted and then we don't even know about it. So, and they are going to be treated for their symptoms, but we need to know what their symptoms are so we can treat it on our end and do follow-up workup as well.
I think as oncology nurses, we're good at focusing in on symptoms. So oftentimes patients want to downgrade their symptoms and say like, well, I've been having some diarrhea, and they try and skirt past it. And then when you ask them, well, how many episodes, and what's the quality, and what's the quantity? Are you eating and drinking? And then they say like, oh, I don't know, it's not that bad. I've had like 6 episodes of diarrhea every day. So that, okay, that's not minimal. Let's escalate this. What are you taking for it? How often? As oncology nurses, you really have to get them to spit out the details so you can better assess your patients.
And I also want to talk about the management of the red flags. I think it's important for everyone to be on the same page as well, the infusion nurse, the OPNs, the clinical trial nurses, everyone that's taking care of the patient and know that they're receiving this medication to be on the same page. I remember one time I received a phone call from the infusion nurse, like, Miss So-and-so's here, she is feeling short of breath. Can you come down and assess her? When I went down, I was like, oh, how are you doing? I know your O2 stat is 92%, but how are you feeling? Is this like something that you've been feeling recently? Is it like a week long, yesterday? And the first thing she said is, it's going to take me off trial. And I said, well, no, it's not going to take you off trial. We just have to do follow workout. So it's important for everyone else to know the red flags in the patient when they see the patient face to face, that they're able to reach out and let you know.
And I know, Dariana, you were talking about, calling after hours or calling your primary team and just showing up maybe to a local ER. I think McCall actually has a good case of hers.
Interesting, related to COVID. So as oncology nurses, I think we have obviously a greater knowledge, different perspective than a regular hospital would. So we had a patient that received 2 infusions of Trastuzumab Resistance, was admitted locally at a regular hospital in Maryland, and he had shortness of breath for 5 days. And he didn't call us. We weren't notified until his second day of admission. And this was right in March 2020. So the frenzy was, everything was about COVID. So, a local hospital is not necessarily going to link shortness of breath with Trastuzumab Resistance. Their go-to evaluations were MI. They did a cardiac workup, CHF. They did a infectious workup. They worked him up for viral illnesses, COVID. They ended up empirically giving him levofloxacin, and they discharged him with that on antibiotics. They presumed he had pneumonia. And luckily, the case was not fatal, but local non-oncology hospitals might not recognize these symptoms. So really stress your patients to call you, and if they're in a hospital, call you right away. He ended up being discharged because of COVID. They wanted as many stable patients out of the hospital. And then when we reviewed the CAT scan that they did, we reviewed with a pulmonologist, and we did determine it was a grade 2 pneumonitis, and we had to discontinue the drug.
Okay. So I actually have a question for the audience. I'm just out of my own curiosity. How many of you have experience with treating patients on ADC?
Some of you.
The light is blinding me, but yes, I see a couple of hands out there. Okay, great. Thank you so much for joining us.
Thank you.
Thank you.
This activity is certified by PVI, Peer Review Institute for Medical Education.